Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The speakers and planning committee members have disclosed no conflicts of interest. To receive contact hours for this CPD session, participants are required to attend the webinar and complete the evaluation form, which will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, we will have time for a question and answer session. You'll see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. To test out this feature, please submit the state or country you are from. We would like to thank our speakers for sharing their expertise with us today. Our speakers are Dr. Bern Melnick and Dr. Sharon Tucker. Dr. Bern Melnick is VP for Health Promotions, University Chief Wellness Officer, Dean of the College of Nursing at the Ohio State University, Professor of Pediatrics and Psychiatry at OSU's College of Medicine. She is a pediatric and psychiatric mental health NP and is globally recognized expert in evidence-based practice, intervention research, child and adolescent mental health, and health and wellness. She is co-editor of 8 books and over 450 publications. Dr. Melnick is an elected fellow of the National Academy of Medicine, the American Academy of Nursing, the National Academies of Practice, and the American Association of Nurse Practitioners. Dr. Sharon Tucker is nationally and internationally recognized researcher focusing on behavioral strategies to promote health and wellness, prevent disease, and reduce stress and risks among children and working mothers. She also is a recognized expert in evidence-based practice and evidence-based quality improvement. She earned her BSN from the College of St. Teresa in Winona, Minnesota, and MSN from the University of Wisconsin, and her PhD in nursing from Rush University in Chicago. In addition to her research and teaching responsibilities, she serves on the board of directors for the Midwest Nursing Research Society and was recently elected as treasurer, and she's an associate editor of Worldviews in Evidence-Based Nursing. Now let's go ahead and get started with today's presentation.
We are so excited to be with all of you today. Even if you're not excited about this webinar, we'd appreciate you acting excited for us. I am so blessed to work with my wonderful friend and colleague, Sharon. And we are here today in our editor roles for Worldviews on Evidence-Based Nursing. You will note, and I will feature this at the end of our presentation, we just published a hot off the press implementation science issue in Worldviews to advance evidence-based practice. Our session today will describe the implementation science as a key strategy for advancing evidence-based practice. I will highlight the ARC model, and Sharon will be talking about a hot off the press implementation toolkit from our full National Institute for Evidence-Based Practice. Lastly, we will highlight challenges and opportunities to accelerate the uptake of evidence-based practices in healthcare settings. Well, I was really hopeful by 2021. I still wouldn't have the need to travel the nation and the globe doing keynotes, workshops on evidence-based practice. I had hoped this would be in the DNA. of every practicing clinician in the world. But I'm an optimist, so I'm going to look at this as we still have a lot of wonderful opportunities for improvement. But implementation science can help us to get there. Well, I've long had a philosophy, and that is, in God we trust, but everybody else better bring data to the table. Unfortunately, it still takes years, even decades, for evidence to be translated from research into real-world clinical practice and health policy. Those of you who are more mature like me, you might remember when the Institute of Medicine's Roundtable, now called the National Academy of Medicine, formed this roundtable in response to the IOM's Committee on Health Professions Education. That committee recommended all healthcare professionals will be educated to deliver patient-centered care, emphasizing evidence-based practice. They also set a goal. By 2020, 90% of healthcare decisions will be evidence-based. I would like to tell you we are 70 to 80% there in reaching that goal. But our recent studies across the United States indicate that, again, we've got so much opportunity in front of us. A recent study that our team at the Fuld Institute did showed that over 2,000 nurses throughout the United States reported they were not even meeting one of our evidence-based practice competencies. So again, we've got to keep beating the drum, conducting our fabulous workshops, creating cultures where evidence-based practice is the norm. Because if we do not get this in the DNA of every practicing clinician in the country, we are not going to meet the quadruple aim in healthcare. EBP plus clinician well-being is the only way we are going to get to the quadruple aim. And I just want to mention we had a very disheartening but important study published on the health and well-being of critical care nurses this past week. That's getting a lot of attention throughout the country, but we need to keep banging the drum. Our healthcare systems need to fix problems that we know lead to nurse and clinician burnout, depression, and suicide. We also need to build cultures of evidence-based practice and wellness. Without those two entities, we will continue to have poor health outcomes and safety problems in the United States and throughout the world. So I started beating the drum on evidence-based practice back in the 90s. And we really put out, with my colleague Ellen Fineout, overhauled this wonderful conceptual framework to support the EBP paradigm. We have got to continue teaching all of our students, our clinicians. Evidence-based practice is a problem-solving approach to the way we deliver care that integrates the best evidence from well-designed studies, a body of studies, with our clinical expertise and a patient's preferences and values. We have so many studies to show when those three entities integrate, clinical decision making is better. We have quality patient outcomes. But if we prepare our students to go out in the world and they go into a culture that's based on, oh, that's the way we do it here, that's the way our outdated procedures say this needs to be done, we're never going to get to that 90% goal. Culture eats strategy for breakfast, lunch, and dinner. That's why we've got to continue to cultivate cultures that make it easy and fun to do evidence-based practice. Well, back in 2000, so 21 years ago, this landmark paper came out, and they talked about this 17-year gap between the generation of research and its implementation in practice. But that's 17 years. If you're blessed, most research never gets translated to practice or policy. We have so got to get a sense of urgency to speed that up. Well, implementation science is the rigorous scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research into regular use by practitioners and policymakers. I always say the gap between what we know and what we do is lethal. That gap contributes to poor patient outcomes, preventable medical errors. So the field of implementation science seeks to systematically close that gap by identifying and addressing barriers that slow the uptake of research-based interventions and evidence-based practices. We need to grow the number of nurse scientists who conduct implementation science. Please note again, this is rigorous research. It is not evidence-based practice. It's research that's going to help us learn how best to take evidence and get it translated in the practice. I don't know if you're aware, but the United States is the worst Western world country to deliver a baby in. 700 women die every single year in childbirth from complications such as hemorrhage, high blood pressure. Many of those complications happen because clinicians aren't following the best evidence-based guidelines. It makes no sense that some practices like this, the tongue patch for weight loss, spread like crazy without any evidence, much to speak of. Other areas where we've got great bodies of evidence that we should rapidly translate in the practice, they're not happening. Right before the pandemic, I was on Capitol Hill meeting with legislators about this issue. And a legislator said to me, Byrne, don't tell me you want more money. There's not going to be more money. I want you to tell me what I can do differently with the money I have. I said, I've got a solution for you. We need to de-implement the practices that we are funding that don't have good evidence behind them, and instead use those funds to get things that work, that have evidence behind them in place. That legislator said to me, but Byrne, you got to realize a lot of our legislators have pet programs. They believe they work and they're not willing to give them up. So we've got to keep beating the drum on these issues. We've got to let go of that's the way we've always done it. And our educational programs have to be so steeped in preparing students, not only how to deliver great evidence-based care, but how to help make culture and systems change if they get out into a clinical site where tradition is the main driver. So we know from implementation science, there are key organizational contextual factors that help to speed the translation of evidence in the practice. These 6 contextual factors are key. Culture, because culture is strategy. Leadership, because if top leaders don't walk the talk, they don't invest in evidence-based practice with their clinicians, it's not going to happen and sustain. Communication, resources, champions, or in my ARC model, I'll talk about evidence-based practice mentors, and then evaluation, monitoring, and feedback. Other key implementation factors are the strength of evidence behind the intervention, beliefs in clinicians about the intervention's efficacy and value. Thinking impacts feeling and what people do. And if people believe that this evidence-based intervention will improve outcomes for their patients, they're more likely to implement it. Feasibility is critical. Ease of implementation is critical. So when we work with researchers who are young and growing their programs of research, we need to be talking to them about designing their intervention with these factors in mind. Is it going to be scalable if you show it works? Support is critical. And I also will tell you, costs are a critical factor as to whether a system is going to adopt a good evidence-based intervention. That's why in our research studies, we need to measure cost and hard so what outcomes that the current healthcare system is really concerned about. We still measure way too many warm and fuzzy outcomes in our field. We've got to measure these so what outcomes, cost, core performance metrics, because if a system is making a decision about implementing or not a new evidence-based program, they're going to want to see outcomes that are important to the current system. We've got to add cost, return on investment, so much more to our intervention studies. I had to learn the hard way. For years, I developed a program to help parents of critically ill children and premature babies cope. We showed through multiple studies, including this clinical trial, funded by the National Institute for Nursing Research, we showed that if parents got this manualized, evidence-based, educational, cognitive behavioral skills building program, not only did parents have less depression, stress, post-traumatic stress disorder, but their preemies did better developmentally up to the age of 3 years. So we published so many studies over several years. Nobody was using my COPE program until I showed in this NIH-funded trial, preemies of parents who got COPE went home 4 days sooner, 8 days sooner for babies under 32 weeks. Once I published the cost effectiveness analysis that showed if every preemie of a parent got that program, we could save the U.S. healthcare system between $2.5 and $5 billion a year. Once I showed that so what outcome, that's when I started getting calls all throughout the United States and globally. People saying, Bern, can you come and teach us how to deliver COPE? How much does it cost? Nobody mentored me back then to think about these things when we're conducting research that are so important for scalability. So I learned big time from that COPE parent work, and I started another path in my research career, developing and testing my COPE cognitive behavior therapy based program for children, teens, and college students. Well, I ended up getting funded by the National Institute of Nursing Research to test this manualized cognitive behavior therapy based program in the schools. We conducted a big randomized clinical trial. This program is all based on CBT. We know cognitive behavior therapy is the best gold standard first line evidence-based treatment for depression and anxiety. But so few people get it because of a shortage of mental health providers who deliver it. So as a psychiatric and a pediatric nurse practitioner, I specialized in CBT. And I thought if I could manualize this program so I could teach non-mental health providers how to deliver it, we could improve the mental health of children, teens, and young adults. And so I created this model that basically predicted if children and teens would receive this, it would enhance their cognitive beliefs that they could feel better and engage in healthier behaviors. And that would lead to all these great outcomes, including improved self-esteem and academic performance. So again, I thank NINR for this funding. We did this trial in 11 schools. And what we found, in addition to drops in depression, alcohol use, and BMI, we showed higher academic competence in these teenagers and higher grade performance. That is the so what outcome that I knew I would have to measure for schools throughout the United States to adopt this program. I just performed a cost analysis on this 7-session COPE CBT based program. Primary care providers all throughout the United States are now delivering this program to children, teens, young adults, and getting reimbursed for it. Again, if you figure out a way to get reimbursed for your interventions, they're going to scale much more rapidly. And I am thrilled to say that after a 30-year research career, my evidence-based programs are being used all throughout the United States and in 5 countries. But I will tell you, this would have never happened unless I measured cost outcomes, unless I figured out a way for providers to get reimbursed, to deliver the program. So back in the late 90s, my colleague Ellen Fineout Overholt and I developed the ARC model, which is used by many healthcare systems throughout the United States and globe. What's different about our model is that it's a model for system-wide implementation and sustainability of evidence-based practice. We've got about 10 studies that support the relationships in this model. The key element in our ARC model is development and use of a critical mass of evidence-based practice mentors who work hand in hand with clinicians to implement evidence-based practice. As a result of implementing this model, so many hospitals and healthcare systems have seen an improvement in the so what outcome factors. So ARC mentors gain skills in the 7 steps of evidence-based practice, but also how do I work with clinicians on individual behavior change and organizational culture change. This is just one study we published that showed the fabulous outcomes that this hospital system showed as a result of implementing our ARC model. Well, again, we have a lot of opportunity in front of us. One of our latest studies showed that, again, nurses throughout the United States admitted they weren't competent in any of these evidence-based practice competencies. Our team from the Fold Institute over the past 4 years has worked with Memorial Sloan Kettering out of New York City. They developed and implemented over 400 evidence-based practice mentors in their system. It will sustain there. We've looked at outcomes, which are phenomenal. Their mentors worked with staff to make evidence-based practice changes that resulted in phenomenal cost savings for Memorial Sloan Kettering. So we do have models, implementation models for evidence-based practice like ARC that we know work. Right now, I'm going to turn it over to my wonderful colleague, Dr. Sharon Tucker.
Fantastic, Vern, and it's a pleasure to speak with you all. I'm going to just cover in review a couple of the content areas or topic areas that Dean Melnick highlighted, just to give you a sense of what led us to develop an implementation and sustainability toolkit that can help reduce this huge gap that Dean Melnick talked about, and to really try to accelerate the uptake of evidence in sustainable ways in practice. And Dr. Melnick already reviewed with you what the definition of implementation science is, and I will highlight just a briefer version of that in a moment. She also spoke about how we have this enormous gap for discovery to get put into routine, hardwired clinical practices. So as you see, this is a pipeline of research in this slide, and we start out with what Dean Melnick talked about with the COPE program, is really testing approaches to improve patient care. And of course, it starts with if there's a risk involved in preclinical trials with cells and bench work and moves into then animal trials. But once we move into human research, that's where we start to look at efficacy. Does it work? Is it safe? And once we figure those things out, and does it work better than placebo, we move into effectiveness studies where we start comparing, is this study or approach, is this intervention approach better than this approach? For whom is it better? Under what conditions is it better? At what point is it better? And what dosage and who delivers it? All those are effectiveness elements that we start to look at. They also move into this implementation science design. And again, highlighting Dr. Melnick's comments about this being very rigorous research. Now we're starting to look at, okay, with whom is it going to be more important? In what delivery mechanisms? Again, I've already said some of this, but now we start to look at if we compare these delivery approaches to this delivery approach, are outcomes better? And that's the kind of implementation trials we start to see. So we're moving from, we know this works, but we want to know now how to get it to clinicians, how to get patients to use it, how to get organizations to adopt it, and how to get it hardwired into practice. And then we lead to public health impact, and we start to see some real change in health and well-being. One other thing that Dr. Melnick spoke about is the systematic review that was conducted by Lee et al. And what I wanted to highlight with regard to sort of a visual is she spoke about culture, leadership, communication, monitoring and feedback, training, etc. What you see in this diagram is really quite powerful. You see the purple box in the middle is leadership. Leadership, you see all those dotted lines to every other one of these characteristics, is really, truly key. If you don't have leaders that support teamwork, that support the mission of the evidence-based practice approach to care, they support collaboration, communication, they support resources, and they generate and allocate resources for finances in terms of human resources and then education and training. They also dictate culture. Although culture can stand by its own, as Dr. Melnick spoke about, but leaders can change culture. And leaders can promote an evidence-based practice culture that will influence the uptake by patients, clinicians, and organizations. And they can also promote the evaluation and monitoring and feedback in routine ways that will help us not only implement and change practice, but sustain it over the long haul. So I love that visual of seeing how powerful leaders are and how these key elements can come together. What you see in this slide is the Toolkit foundation that we generated. We built it off the ARC model that Dr. Melnick has already spoken about, but we decided we really needed this because what often happens in the thousands of people we've trained through our evidence-based practice intense immersion, which is well received, teaches people and gives them the skills and knowledge, but what often happens is they get back to their organizations, and for all the reasons I just talked about in the previous slide, their projects get stalled, or their effort gets stalled, or the movement toward an evidence-based culture gets stalled. And so this implementation toolkit that is available within the fold provides that real intense stuff to move the institution and leaders along from the conceptualization into implementation and then finally into sustainability. And with sustainability comes the need to continue to reevaluate, because as we develop new science and new ways of doing or providing care and improving outcomes, we will change, and this is a continuous change model. So our toolkit includes EVP concepts, the strategies to be effective in healthcare settings, how we promote that uptake that the implementation science discovery has taught us. It includes outcomes of EBP educational programs. It incorporates change models, leadership theories, attributes, and then mentoring theories, which is a key element of the ARC model, as well as we've built in a number of implementation strategies. I should point out, we added to Dr. Melnick's figure, if you see in the EBP implementation, a little pound sign that takes you over to the left there and just indicates that along with the other elements of the ARC model, this toolkit is key. So there are several elements, and I'm going to go through these relatively quickly so that we can allow some time for questions, but we do try in this approach and in this toolkit to align with standardized nomenclature from the literature so that we can compare our work with the work that others are publishing, so to continue to advance the science. And we also bring the culture of EBP to organizations through this standardized approach and standardized language as well as our teachings. We have these sections in the toolkit. We have the initiative that is a chartered approach, which comes from the quality improvement literature and processes, which I'll briefly say something about. We have a planner and timeline that we have provided as a tool because it's essential that you operationalize this from the beginning. Who's going to do what, when's it going to be done, and what is specifically is going to be done. And then we have a number of elements that I'm going to very briefly show you that focus on that implementation and sustainability, a couple of checkpoints, and then tools and strategies that you can consider for your initiatives and for your organization as you move this forward and accelerate the practice change in your organization. And then finally, we provide a number of summary report templates that you can use to communicate up the chain at your organization. So this document you see here, it's actually 3 documents in front of you, is really our charter. And what you see happens in the charter is it's who's the leader, and we provide a few different, the 2 pages to this, and then what you see in that 3rd element on the slide here is an example. So the charter includes the team leader, the significance or background of this. It includes what the clinical, who the team is, what the clinical inquiry is. Inquiry question, what we want to do in this organization is not the PICO question. It is what we want to accomplish here. That's the inquiry based on the problem. And then we use the PICO to drive what does the literature tell us is the best evidence. And those are related, but they're not always the exact same. And then you get into outcomes and you get into the team, and that puts forward the project charter as to how you're going to drive this project in your organization. The next thing you see here is the evidence-based initiative planner and timeline. And what we have shown, or what we've argued in this particular document, is that it starts with being able to identify what the problem is, the issue to be addressed. It points out that you've got to have the PICO question identified and investigated, of course, developing those evidence-based recommendations from the PICO search that you did in synthesis of the evidence and synthesis of the outcomes, moves into your plan for developing or for implementing your outcomes to be measured. It includes the value on investment and return on investment elements, facilitators, barriers, the team, communication, the engagement of stakeholders, providing information, the rollout of the change incrementally, evaluation, the sustainability plan, and then the executive summary and celebrating success and dissemination at the end. And so that's what, who, and when that you're going to document and track all along the project's duration. What you see in this particular slide are the 3 different report templates that we have created for you. And there is the initial one that you're going to outline what the project's going to be about, who the team leader is, and what you're going to actually do. And then as we move along, the next one you're going to do is you're going to be continually updating the team in a very succinct 1-page. Each of these are 1-page documents that, again, to tell the leader this was the scope of the project, this is who's leading the project, and here's the update of the progress that the project has made. And then in your final report, you're certainly going to report your outcomes, what actually happened, the sustainability plan, and how the program is going to be, how the findings are going to be disseminated both internally and externally. And then the last number of slides I want to show you are, we have a pre-initiative, the building the case, checkpoints, implementation and evaluation, and then sustainability. And within each of these, you're going to see that we start with, we have the yellow, which is your pre-initiative strategies and what you're going to do. We have the light green, which is the first building the case, checkpoint 1, and the things that you need to do once you've got your project starting. Then there's the building the case, and again, this is all around building awareness, building knowledge, creating interest, and really influencing beliefs in these 2 checkpoints. And then you really move into the rigor of implementation and evaluation, the blue documents or templates, and then finally sustainability and intentional reassessment. And again, that's where you move into integrating new evidence. And that's the purple color. And then within each of those, what you will see is we have designed a leadership checklist of things they're going to do and the mentor. And the reason that's really important is in the ARC model, mentors are real key to success. I'm going to move here. These are just a couple of examples. I'm going to move these slides forward. But the mentor is key to success, as is the leader, which we've both identified from the scientific literature and all of our experiences. So in all these documents, you're going to see that there's a template or a checklist or a list of activities that you can choose to do that are going to fit with your project and fit within your organization in the context, meaning the population, the setting. You're going to have a checklist for leaders and a checklist for mentors. But each of these go through those phases of the pre-implementation, then you move into the building the case. I think that I'll stop here, but just building the case. And then you move into the actual implementation piece of it, all again having both leader and mentor elements. And then finally, we move into the sustainability and the reevaluation in a continuous way. So we hope you find that this toolkit could be extremely useful to you to move the project from idea inception all the way through to hardwiring it and monitoring its success as you go. So I'll turn this back over to Dr. Melnick.
Thanks, Sharon. People are so excited about this implementation toolkit because it really is a roadmap for evidence-based practice change in healthcare organizations. And we so hope it is well used for sure to improve outcomes. So Sharon, do you want to go to the next slide? Because I think you still have control. So Sharon Molly McNett, who is the Assistant Director to the Implementation Science Core with Sharon of the Full National Institute. Sharon and Molly said to me, let's do a whole themed issue on implementation science. So we delivered that. That's hot off the press. And I will tell you, there are fantastic articles in this special themed issue that I'm biased, I know, as editor of the journal, but I would put this in the hands of everybody I know. There's such cutting edge implementation science work in this issue. Next slide, please. So this just gives you an exemplar of the articles that are in this issue. I want to call your particular attention to this first one. Sharon led this effort with a group of us, but this is the first time application of evidence-based practice models to improve healthcare quality has been published like this. Earnhardt and colleagues have a wonderful paper on validation of the implementation climate scale in nursing. I'd really encourage you to look at all of these fabulous articles. Next slide, please, Sharon. The last set of articles, again, really terrific. This one examines factors associated with implementation of evidence-based management practices for improving nurse work environments. It is a fantastic paper. They're all worth reading, really. At least the abstracts, they are that good. Next slide, please. So Sharon and I would like to invite you. We have a call out for papers now for a special themed issue in January that'll focus on nursing interventions to improve cardiovascular health and lifestyle behaviors. Cardiovascular disease is still the #1 killer throughout the world, and nurses can make such a huge impact to promote healthy lifestyle behavior change, to manage high blood pressure, and to prevent cardiovascular disease. So please, consider submitting if you have work in this area and spread the news about this call for papers. So with that, I am going to open it up because we actually have 9 minutes for questions.
Where can we find the toolkit, and does the toolkit cost anything?
Sharon, why don't you take that?
The toolkit is part of our amazing fold resources, and it's very inexpensive membership. It is about $100 a year, and it is chock full of our evidence-based toolkit in general, all of the resources that we connect people to, and our toolkit. So if you wish to be if you want to get involved and get enrolled, just go to our website and you can actually sign on to become a member. You can also go through one of our immersions, which then it's provided to you as well for a period of time.
The ARCC Model, a suitable framework to guide a national study of evidence-based practice baseline competencies in a low-middle income county with no prior significant investment in evidence-based limited evidence-based practice education among nurses, no policy requirements for evidence-based practice, etc. Is that model suitable?
Absolutely. I think it would be an awesome model for that specific entity. I really do. Because again, what you're doing, I mean, it's like Sharon and I talked about with having evidence-based practice mentors in place. Our clinicians these days, honestly, are very overwhelmed. There are so many tasks that have taken them away from the joy of having more time with their patients. So again, by having ARC, evidence-based practice mentors in place to empower clinicians and help them implement best practices, it truly takes huge barriers away. But the other piece is you will save dollars with implementation of this ARC model because evidence-based change will be made. And if you evaluate your outcomes, including costs, you'll be able to go back to your C-suite and say, because we changed this practice, maybe to prevent colies or falls, it resulted in $1 million worth of savings to this hospital. We want half of those savings to come back to nursing to further fuel our efforts because of what we showed we can do. I think it's very applicable.
What components or steps of the toolkit address health disparities and racial inequalities in care?
Could you say that latter part again? What part of the toolkit addresses what?
Health disparities or racial inequalities?
Well, we have a number of elements on patient preferences and adaptation to patient unique characteristics. We could we could do a better job of calling out, and we will as we continue to evolve the toolkit, of calling out specifically health equities, which we don't do specifically in the model now. But we have so many different strategies that are geared to the elements of the evidence-based practice definition, which of course is not only the evidence, but also clinicians' expertise and patient preferences and values. And so we strongly believe in the patient collaborative approach. And so I think that as you go through, you'll see those. But I would have to say we can improve on the disparities and health equities.
We'll take that back to our team. So thank you for posing that question for sure.
What are your suggestions about working with our different levels of nursing education, BSN, MSN, DNP, particularly with the mentor concept for coaching?
I think if you are familiar with our book, the one Ellen Feinert Overholt and I did, it's going into its 5th edition. We have a whole chapter devoted to teaching evidence-based practice and leveling that out across programs. We also have another book that's published by Sigma that I think is a fabulous book to teach especially baccalaureate students about the steps of evidence-based practice so that they meet the competencies. So those are two really good references that has some good content to guide you.
What would you recommend as the starting point for someone in an academic position who is attempting to gain entry and acceptance in the healthcare setting?
I'm assuming that is in relationship to evidence-based practice. I think that the best thing to do is to find your key partners, find your key champions that are interested in partnering and that are interested in improving patient outcomes and improving other kinds of outcomes, system outcomes, and cultivating that relationship to start and getting a sense of a shared vision and a shared approach to how we can have a continuous quality improvement approach to the care we provide. That's what I would suggest. Vern, anything else?
I always say when you go into a new organization, look for the people with a twinkle in their eye and a fire in their belly. Think about, because it's hard to believe that there would be people who resisted this wonderful evidence-based movement. But there are, because people are still steeped in tradition. When I was younger and less wise, I really did spend way too much time trying to convince the resistors to jump on the evidence-based practice train. But as I got wiser and more mature, I now, because I'm a big vision person and a mover and shaker. And if you want to get things done pretty quickly, you go into a new organization and you look for those people with a twinkle in their eye and a fire in their belly, and you start running with them. The rest will come.
Thank you so much for today's presentation. As a reminder to our attendees, please submit the state or country you are from in the questions feature. We hope you enjoyed this webinar. Be sure to check out Sigma's upcoming webinars, podcasts, and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars and podcasts are freely available on the Sigma repository. Again, thank you for the presenters today for this great information. Sigma is grateful that you took the time to share with the audience, and we look forward to hearing more from you in the future. Thank you and have a wonderful day.
Bye.
Bye-bye.